You're watching Cetome TV. Knowledge is power.
So now we're going to go into the fascinating world of lung cancer treatment.
Okay.
And just where things are at right now.
Yeah, it sounds really exciting.
So when I hear from patients with lung cancer, the first thing I ask them is, what have you been tested for? And they say, oh, well, my doctor tested me for EGFR and I don't have the mutation. And I'm like, we have 8 molecular targets right now, if not 9 molecular targets for lung cancers. That means
not just EGFR.
Exactly.
Right.
So what that means is you must get tumor DNA sequencing. You want to know what your targets are. You have to know that information. It's so important.
So if your oncologist tests you for one mutation, that's lovely, but it's not sufficient.
You need to get, if you have lung cancer, invest in tumor DNA sequencing.
Because you can look at, right now, some very excellent tests are giving you between 350 to 550 molecular targets. That's a lot of information.
And for lung cancer, you just need to know whether it covers these 8 targets that we're going to discuss today.
Okay.
So the first target, EGFR, epidermal growth factor receptor. This was the poster boy for precision oncology. It was one of the first molecularly targeted mutations, that and HER2. So what this was, this created the development of the NIBs. The NIBs are referred to as tyrosine kinase inhibitors.
Okay.
So with HER2, that was the development of the monoclonal antibodies, Herceptin. And for EGFR, that was the development of the tyrosine kinase inhibitors.
Okay.
And so the first 2 tyrosine kinase inhibitors were erlotinib and gefitinib.
Okay.
They were both considered, and they've been around for quite a while. And they radically changed how people with EGFR mutated lung cancers responded. It doubled their survival in some cases. Now, these are what we call reversible inhibitors. And so they inhibit, but their inhibition can be reversed. And patients often became resistant to these treatments after a few years of being on the drug. While it did provide many years of cancer-free life for patients with EGFR mutations, there's a series of mutations that actually cause these drugs to stop working. And these are what we call emerging mutations, or mutations in other genes.
So they either come out over the course of your cancer treatment?
In response to the treatment, believe it or not.
Okay.
That we believe.
All right.
So the mechanisms to these are called reversible inhibitors. So the mechanisms of resistance to these reversible inhibitors are copy number variations. That means multiple copies of a gene called c-MET, and then also in the IGF-IR genes.
Okay.
Or insulin-like growth factor 1 receptors.
Okay.
And then also mutations in the PTEN tumor suppressor gene and the mTOR signaling pathway. And then also there's what we call secondary mutations in the EGFR gene. So erlotinib and gefitinib work specifically for certain mutations in EGFR.
That's a lot of information that you need to know just for one gene, especially when there can be many
involved. We haven't even started.
Okay. Okay. Hang on.
So what happens in these patients is they develop mutations in PTEN, mTOR, EGFR, other mutations in the EGFR, or even HER2. And HER2, as you know, is common in breast cancer, HER2 positive breast cancers. So there's also a new mutation called an emergent mutation in the EGFR that was called the T790M. And what happens is when these tyrosine kinase inhibitors, when they bind the EGFR gene, the receptor, when they bind it, what they do is they cause it to they prevent the signaling of it as it's using the cell. So when you get an EGFR T790 emerging mutation, what happens is it causes a kink in the receptor, so those other drugs can't actually bind it anymore. So it creates this physical barrier to these reversible inhibitors from working.
I see.
Yeah.
And is that reversible?
not sure what you mean.
Oh, well, I'm just thinking if these things if they come up in kind of response to treatment, is it, if I stop the treatment, will I be able to use them again later?
That's an interesting question. So, I didn't even think of discussing that, but you're opening up a whole new area of research.
Oh, okay. Later. Another time.
Well, just to give you a summary of what you just were basically
A new field of study
alluding
I just
to.
created.
You didn't create it.
I'm
but
kidding. Of
alluding
course.
to is basically what happens is you have this subset of different populations of cells. So you don't actually. So there's two different things that can happen when you become resistant to this.
Mm-hmm.
A new population of cells develops this T790M mutation. It's not necessarily the old ones. So, so there will still be your previous cells will continue to respond to erlotinib and gefitinib. It's just that this new subpopulation of cells that are driven by a secondary EGFR mutation are now taking over.
Okay.
And so this is called a emerging mutation. So it's kind of microevolution. So that's what you're referring to. So, you know, a lot of doctors will say, well, you're not responding to the EGFR inhibitor anymore. We're just going to take you off it. And that's a bad mistake because you are still responding to it. It's just that you have a new population of cells that is not responding to it. And so that's kind of what you were insinuating.
Right. And
So,
how would I know?
well, you can assume that you're still going to be preventing certain cells from arising. Unfortunately, the way they test for EGFR T790M mutations is they look at the biopsy, but really that's not the way to go because it's an emerging mutation.
Right.
It's going to happen in a very small population of cells,
Right.
and you may just pick a biopsy that doesn't have that. And it may not be in all of the cells in that biopsy. So what we do is we use liquid biopsies. And it's the only way to effectively tell if you have an EGFR T790M mutation.
So blood-based test.
Blood-based. And this is true for all of the other emerging mutations. We always use a blood-based test. We have exosome-based testing for MET mutations, for P10, EGFR, HER2. We look at HER2 copy number variation. There's all kinds of things we can do with liquid biopsies.
To keep an eye on any changes.
Because they're
since
so
your tissue
sensitive, they
biopsy.
look at the entire system. They don't just look at a biopsy. So those two drugs were what we call first generation EGFR inhibitors.
Okay.
Then they came out with a second generation inhibitor called afatinib. Now this is irreversible. And interesting enough, it also targets HER2 as well as EGFR. So this came out just after erlotinib and gefitinib. And it was a drug that doctors would typically give once patients became resistant to erlotinib and gefitinib. Now they would often give this drug without actually determining what the mechanism of resistance was.
Right.
We would definitely look at the mechanism of resistance and then target that,
But that's
rather than just giving a new drug.
what you just said is a really crucial point because there's a lot there's a lot of confusion out there among oncologists and even researchers as to how effective certain treatments are based on just that thing.
Exactly.
That they weren't monitoring the proper mutations to be able to tell why a treatment did or didn't work for somebody and instead just assumed, oh, well, that's not as effective.
It's actually called a lack of patient stratification.
Okay.
And interesting enough, when erlotinib and gefitinib first came out, there was this big clinical trial where they took all of these patients with lung cancers and they gave them these drugs. And both drugs failed. And so then, the doctors were like, well, wait a minute, these drugs don't work on lung cancer patients. They failed the statistical averages. So some of the scientists looked at it and they said, well, wait a minute. You weren't testing these patients to see if they had EGFR mutations. You just randomly took non-small cell cancer patients. So they went back over it and they found that the patients that did respond in these trials had these EGFR mutations and the ones that didn't. And so that was the big lesson of precision oncology. Patient stratification is so important. And today people still forget these important lessons we learned from the IRESA and Tarceva trials.
Well, and what you mean in this case with precision oncology, what you mean by patient stratification is the molecular profiling.
Exactly, and the continual molecular profiling using liquid biopsies and new technologies to detect these emerging mutations and treat the emerging mutations while still maintaining treatment that is effective for the original mutations, getting all of the populations of cells, not just one.
So this is really new.
So there's a drug called Tagrisso that came out. And actually, we had one of the first patients in Canada on Tagrisso a few years ago. We've been following it for quite a while. Tagrisso was designed to target the T790M mutation. And so obviously this is, a huge breakthrough. So when we first started seeing this drug about 3 years ago, we tried to get all of our patients in the trials, and we had some phenomenal results. Patients that had stopped responding after 4 or 5 years on olatinib and gefitinib, all of a sudden they started responding again. Now, we did check our patients to make sure that the reason they were becoming resistant to these treatments was T790M. So we made sure we stratified those patients. Some of those patients did not have that mutation, and they had other mutations like MET or P10 or mTOR or HER2. So therefore, we would give them different drugs. But in the cases of Tagrisso, it was an amazing, amazing drug. So Tagrisso was actually approved in Canada in January of 2018. Surprisingly, a lot of doctors still do not know about it. We had this terrible case last year. And so Tagrisso is actually approved for first-line metastatic EGFR positive lung cancer. Now Tagrisso is an irreversible, but it's also what we call irreversible and selective. So while afatinib is irreversible, the problem with afatinib and olatinib and gefitinib is they don't just bind the mutated EGFR, but they bind the healthy, normal version of it. And so because of that, you get side effects. Because EGFR is very important in skin, and all of your organs have skin, and skin is all over your body. So if you suppress EGFR, the wild type version of it, that's in your healthy cells, you're going to have some side effects. And so afatinib obviously has more side effects because it binds more targets, and it's irreversible, unlike olatinib and gefitinib.
And remind me again what irreversible means.
Well, that means once it binds onto that protein, it does not release.
Okay, got it. Okay, and the Tagrisso?
Tagrisso is irreversible, but it's also selective. So it's selective for the T790M mutation.
Which you don't.
It's not just random, right? Which is the emerging cancer-causing mutation.
Okay, so
the Aurora 3 trial really showed the benefit of that. And so for patients that have become resistant and had multiple treatments, these are patients that were being treated in the second and third line of treatment, where chemotherapy is completely useless, and obviously the EGFR and the afatinib is not working anymore. These patients were typically sent off to die. With Tagrisso, 66% of those patients got a response in their second and third line. These are patients that have had a lot of treatment and have heavy metastasis all over their body. More importantly, the progression-free survival for these patients was almost 10 months. And the overall survival, and that's the average, the median overall survival was 27 months. It was 26.8 months to be exact.
Wow, almost 3 more years.
Almost 3, 2.
Okay, all right. I'm exaggerating ever so slightly. My math is
over
up.
2.
Okay, just over 2.
But you made a good point there, because the confidence, the 95% confidence interval for this study, and so that is a range. So the average, 50% of the patients lived 26.8 months. However, some patients lived a little less, and some patients lived more. And some of the patients that live longer are still cancer-free to this day. So they were literally cured. So you have this range with an average of 27 months. Some patients didn't live that long, probably because they didn't have the T790M mutation, or they had these other emerging resistance mutations. And then the patients that did respond did really well.
Wow.
And so at 12 and 24 months, the overall survival was 80% at 12 months and 56% at 24 months, which is huge.
It is when you think that you've already gone through 2 or 3 types of treatment. You've been told, that's pretty much it.
It's death sentence.
And then here's this thing that's just wiping it out.
And what they found out too is that not only is Tagrisso effective at a late line, because this is what they usually use these drugs for, they start out with the late line. They found out that it's incredibly effective when you first start treatment.
So if you know your molecular drivers of your cancer before you start treatment, you get the right stuff right from the start.
So it was approved in 2018 in Canada. Very few doctors took it up. And
so that means it's available in the U.S. if that's where you're watching
Yes.
from, and you can get it elsewhere around the world.
Yes, definitely.
But definitely.
So we had a very sad case of a patient that was diagnosed just last year. They were diagnosed, I think, we saw them in April, I believe.
Okay.
And so they were on Alontinib. And so I asked the doctor, I said, why are you not on Tagrisso? It's free. The drug company's providing it for free, and it has a much longer survival rate. Plus, it also takes care of this T790M resistance mutation, and it has less side effects. It's such a great drug. Why are you using Alontinib? He says, well, I didn't know it was available. So unfortunately, we went back and we tried to get the patient on it because they had stopped responding to Alontinib, and the indication was for first line. So since they'd already been treated, they were not allowed this drug.
Not covered under public health care. They could have got a hold of it.
They could have paid
had
for it
the
out
money.
of pocket. Yeah. So that was a very sad
That
situation.
is very sad.
The patient
because
ended up dying.
That right there is one of those cases that I talk about a lot, which is where because that information bottleneck. Too much information coming out right now all the time about new treatments. The oncologists can't keep up. So they're not going to be able to know all the bits and pieces.
Yes. And so we have another player called dacomitinib. It's another tyrosine kinase inhibitor. That was approved in 2018, I believe, September.
Okay.
And so that is another selective and irreversible inhibitor. But instead of just targeting EGFR, it also targets HER2 and HER4, which are both resistance mechanisms.
So it covers a lot of bases.
Yeah, a lot of bases, yes, definitely. So we'll leave EGFR alone for now.
Sure.
But there's just some amazing developments in it.
That's great.
So now there's also BRAF, which is common in melanoma. Okay. BRAF mutations. There's 2 drugs for that called vemurafenib and dabrafenib. They're getting great results. So if you have BRAF positive non-small cell lung cancer, you can use these 2 treatments. And then KRAS. KRAS has been a big problem for many, many years. And that's because KRAS was considered not druggable. It was, one of these first oncogenes where
to be
they're
resistant to...
Yeah, it's just really hard to drug it. And that's because of the shape of the protein. It doesn't have a lot of accessible points where the drug can go in and bind and alter it. So recently, there's been an amazing new development of a type of drug called a small molecule inhibitor. Now, I remember first learning about small molecule inhibitors way back in 2000. They were just used in the lab and they didn't have any application. But we discussed tyrosine kinase inhibitors briefly. So this new drug for KRAS, they're able to target it. They tried targeting it with tyrosine kinase inhibitors, but it didn't work. So they now have this new drug that targets KRAS mutations using a small molecule inhibitor. I think probably what we should do is talk a little bit about tyrosine kinase inhibitors versus small molecule inhibitors. I think we should probably do a little video segment on that alone, but I think I'm just going to briefly go over the difference here. So basically, when a protein, like an oncogene that causes cancer, is activated, it's activated by a process called phosphorylation. A phosphate group is added to the protein.
Okay.
Now, TKIs, these drugs, tyrosine kinase inhibitors, can interfere with these signaling pathways in 4 different ways. Number 1, they can compete with what's called the ATP binding pocket. And that's where the phosphorylation happens. It happens at this place called the ATP. And so, as you know, ATP stands for adenosine triphosphate. It is basically the currency of all living creatures. It's only made by plants. It's not made by humans, but what humans do is they get it from other species by eating those species, and they can recharge it. And what they do, so our entire metabolism, everything we do is based on adding a phosphate group to adenosine mono or diphosphate, or adding two phosphate groups to adenosine triphosphate.
And we do that through the foods we ingest.
Yes, exactly. Yes, exactly. And we have to ingest it. So we actually, we gain our ATP, right, our ADP and so on from the foods we ingest. We recharge it. So when you activate something, you spend, it's like, think of a bank account. ATP is a full bank account. When you take a phosphate off and recharge a molecule, activate a signaling pathway, then you now have ADP. So you've lost that phosphate. So that's like making a withdrawal. If you do it again, then you've lost two phosphates. So now you're kind of getting into the red and you're getting into your bank overdraft. So you have to go to work and you have to add some more money to that account. And you recharge by adding a phosphate group to AMP, and that causes it to become ADP, diphosphate, and then you add another one, and it's called ATP. And that's what our whole respiration system of food does, is it recharges ATP.
Okay.
So we use up ATP, and then we recharge it.
Makes
And
sense.
so activating one of these signaling pathways uses ATP.
Okay.
And so what tyrosine kinase inhibitors do, one of the ways they can do this is they can interfere with that addition of the phosphate group. So, they can compete for that they compete for that location on the protein with the ATP molecule. So all of a sudden the ATP molecule can't go there and bind it.
Got it. Right.
You can also interfere, tyrosine kinase inhibitors also work by interfering with the substrate. That means whatever molecule is attached to that signaling pathway. Or tyrosine kinase inhibitors can work on both pathways. They can interfere with ATP and the substrate. Or they can also, the fourth way they work is through a system called allosteric inhibition. And so basically what they do is they occupy a site on the protein that causes the protein to change its conformation, and that change in conformation prevents the ATP from binding and activating it.
Wow.
So this is the different ways that tyrosine kinase inhibitors work, and each one works slightly differently. So it's important to know, if you have a tyrosine kinase inhibitor, it's important to know how they work and which one is best for you.
Right.
Now, in all cases, what tyrosine kinase inhibitors do is they lead to a process called ubiquitination. And ubiquitination is basically a process where a protein or the product of a gene or an enzyme is tagged for degradation. And so when something is ubiquitinated, it's a tag, and it says throw this in the garbage. It's dragged over to what we call proteasomes, and the proteasomes break it down and recycle everything. So in all cases, that's how these tyrosine kinase inhibitors work. So these did not work for KRAS, but a small molecule inhibitor that actually goes in and binds it. Now, we won't get into small molecule inhibitors right now because it's a much more complicated process.
Okay.
But these small molecule inhibitors, because they're so small, they're able to enter the cells freely, and they're able to enter the cancer cells, and so therefore something like pancreatic cancer is going to respond much better to it. So we have hope for that.
Yeah.
So a very recent study, just in last year's ASCO, just a few months ago, they presented this drug called AMG 510, a small molecule inhibitor for the KRAS G12C mutation.
Okay. Wow.
And
Getting pretty specific,
yeah,
isn't it?
incredibly specific. So KRAS G12C, it occurs in probably 10 or 11% of non-small cell lung cancers. So it's a good drug, or it's a good target. And they gave it to a bunch of patients that are really sick, and they've been through a lot. In 56% of the patients, they had a disease control rate of 100%. 56% of those patients, 100%.
Wow.
And in 54% of those patients, they achieved a partial response. That means some of their tumors, this is based on the RECIST criteria, some of their tumors responded, some of them didn't. And then 46% of those patients achieve stable disease while on the drug. So this is a new horizon in the treatment of cancer.
But it goes to show when you can drill down, like you can with this genetic testing that's available now, and you can find out what's driving someone's cancer, and if you keep an eye on it with those liquid biopsies, so you see kind of what's emerging mutations as you're going. 56% of this one group had 100% response.
Yes,
that's amazing.
It is for such late stage, and KRAS KRAS-driven lung cancers are really tough to treat.
Wow.
They don't respond to EGFR inhibitors. They don't respond to immunotherapy.
That's great.
So this is a new horizon.
Yeah.
So I envision within the next few years you'll go in with your sequencing results. The doctor will say, okay, let's see your sequencing results. You have, KRAS G12D, you have a BRAF V600A, you have this. Come back in 3 months and we'll have a drug cocktail that's perfect for you.
Well, hopefully it won't be 3 months.
Well,
I understand what you're
getting.
It'll
be 3 months.
Okay, I'm sorry, I picked up on the wrong point there. The point is...
Okay, this took 30 years.
Okay, all right, I'm just saying. I want my treatment now. I don't want to wait 3 months. But, okay,
You see where we're going with
I
this.
do. The fundamental point is it's going to be true precision oncology,
really
very personalized
some
cancer
amazing
care.
things. Yes, yeah. And so now we'll get into some of the other recent, and now these are not so recent, they've been around for a while, but we also have drivers of cancer called ALK, ROS1, which refers to reactive oxygen species. The ALK is an anaplastic lymphoma kinase. I don't remember all of these, but then there's MET-driven cancers, and then there's another one, NRTK1. NRTK1. And so these are all mutations that are found in various patients that now have drugs, and very, very effective drugs. So you want to make sure your doctor's testing or that these are on your tumor DNA sequencing panel. And so one of the drugs, ceritinib, targets ALK. It's very effective. Alectinib targets ALK. Now, once again, these are all tyrosine kinase inhibitors. So they're kind of old school, but they've been around for, a few years.
Okay.
Then you have brigatinib, which targets ALK and ROS1. Then there's lorlatinib, and that targets ALK and ROS1 too. And then there's a new one, crizotinib. Well, it's not that new, but it targets ALK, MET, and ROS1. And then we also have a very new one, which is really exciting. It's called entrectinib, and it targets ALK, ROS1, and NRTK1 to 3. So, regardless of whether you have one or two or a combination of these mutations, there's a drug for you.
And that's why you're calling it exciting, really.
Yeah.
Is because there's so many options.
Yes, totally.
To have those mutations.
Totally, yes.
Yeah. And something that you said earlier, you kind of skimmed over it, but it's a really important point, which is that these types of treatments typically provide patients with hugely significant benefits with fewer side effects.
Yeah. And a lot of these drugs, not all of them, you have to look at each specific drug, can pass the blood-brain barrier. And so they can treat CNS metastasis, which is really important in lung cancer.
That's good.
So now we need to get onto some other drugs. And of course, the biggest breakthrough in any kind of cancer is always going to be immunotherapy. And lung cancer was pretty well the second cancer that was the target of immunotherapy.
Okay.
So we'll get into that in a second, but first I just want to mention a drug that you use a lot of. It's called zoledronic acid. It's also known as Zometa. It's a bisphosphonate. It's a very powerful bisphosphonate. It's very cheap. You get it once every 3 months. It's used for osteoporosis.
It's called Zometa?
Zometa. Yes.
Okay.
It's known as zoledronic acid.
Okay.
And so we give it to patients with breast cancer and prostate cancer. It's very cheap. It's about $600-700 a year. Unfortunately, it's not covered here in BC. In BC, they cover some of the lesser forms of bisphosphonates that are not as effective as Zometa. But an interesting study in Zometa in lung cancer, we've been using it in lung cancer for probably 8 years now. This study showed that although this drug is involved in preventing osteoporosis in women that are on anti-estrogen therapy, it also has cancer-fighting activity. And so in lung cancer, it actually increases survival time to 385 days in this subgroup of patients versus 275 days. So these are, late-stage patients that, didn't have any treatment options, didn't have any targeted therapies. And so their doctors just gave them Zometa alone. And I think they may have had some, capecitabine, palliative chemotherapy. So these are palliative patients, but added well over 100 days to their life. So that was quite significant. But more importantly, it lowered the incidence of malignant pleural effusion, and that is a real problem with lung cancers. And that's where the pleural, the lining of the lungs, gets inflamed and gets fluid in it, and it can be very, very painful. It can causes breathing problems, and obviously it leads to death in many cases, makes you susceptible to pneumonia, infections, all kinds of things. So it actually reduced the incidence of that in these patients.
So is that for these late stage patients?
This is for anyone. Anyone who's on lung cancer, we always suggest getting
Zometa or zoledronic acid.
Yeah, because it's got literally no side effects, and it's so cheap.
And it's inexpensive.
You get a shot every 3 months.
So even if you're very late stage, it'll help you somewhat. But otherwise, as a lung cancer patient, it'll make you less susceptible to certain infections.
Yeah, malignant pleural effusion and water in the lining of your lungs.
Yeah.
Or fluid.
That's exciting.
Very,
so that's
very
a simple
fix.
Now, is that what is referred to as an off-label
Yes, that's an
treatment?
off-label approach.
So something that was created for something else, but happens to have this benefit.
Yeah. So we spent a lot of time on that. So it's not even considered a cancer drug.
Right, but it makes a big
Designed
difference
for osteoporosis,
to people.
So now we're going to get into immunotherapy very briefly, because if you look at the numbers of the immunotherapy trials, you'll see we're getting into the hundreds for the different drugs.
Wow.
So
100 different types of immunotherapy.
No. I will explain that in a minute.
Okay. Hundreds of clinical trials.
Yes.
Okay.
Hundreds of clinical trials, yes. So immunotherapy, what we know, indicators for response to immunotherapy, and we always look at prognostic features and indicators of response.
Okay.
One of the things that seems to really be an effective guide for immunotherapy in lung cancer, and this seems to apply to all types of lung cancers, is high PD-1 expression. So if you have over 50%, you're going to have a great response to immunotherapy. Even 1 to 49%, you're going to have a good response. Now, the problem is PD-1 is often determined using biopsies. Not a good way to do it, because there's a lot of discordance between biopsies.
Right.
So we recommend that you look, if you're going to do PD-1 testing and you're not going to look at the blood and do a liquid biopsy, then you need to look at 4 separate biopsies. Because there's going to be a lot of variation between those. So one biopsy may have low PD-1, and all of a sudden your doctor's saying, well, you got low PD-1, we're not going to give you immunotherapy.
Right.
And then another one may have high PD-1. So you have to look at least 4 different biopsies.
Okay. But most people don't have 4 biopsies.
No, I know, and that's a bit of a problem.
In which case, because immunotherapy can be so incredibly beneficial, if you have PD-1, you want to definitely have a blood-based test for that. Then.
And a tissue-based too as well.
Okay.
You want to look at it from different angles.
All right.
So another thing that determines whether these immunotherapy works well in lung cancer patients is your MSI status, your MMR. And we discussed that in last week's immunotherapy. So MSI is microsatellite instability, and MMR is mismatched repair. Interesting enough, being an ex-smoker is a good prognostic feature for immunotherapy. And that's probably because all of the different mutations that smoking causes really make the cells stand out to the immune system. So, smoking has a lot of carcinogens. And so it really damages the DNA in your cells. And so that's going to be much easier to recognize by the immune system.
So when you boost the immune system with immunotherapy, it's going to find those.
And it's going to have an easier time of recognizing and discerning what's a cancer cell and what's not.
It's not a good reason to start smoking.
No. Now, interestingly enough, tumor mutation burden, in other words, the amount of mutations, at this time, we originally thought it was going to be a great tool for every cancer, but for some reason, lung cancer is not the best indicator. No, and that's probably because in the study that looked at tumor mutation burden, there's a lot of variation in how they determined tumor mutation burden. And then they didn't necessarily stratify for the specific mutations. So whether it is or not a factor, we don't know yet. The data is saying no, and obviously we have to go with data, but you have to stratify too. You have to look at the different mutations.
So MSI and MMR are good indicators for this type of cancer, but not the tumor mutation.
Yeah, so those are a type of, MMR is mismatch repair. So it's a type of gene involved in DNA repair. So I just want to briefly talk about some of the new combination therapies. And so Keynote 189. We started with Keynote 1. That was the first immunotherapy trial.
Wow.
And so Keynote 89 is just another one in the Keynote studies. Okay, there's many Keynote studies.
189 of them?
No, there's more than that.
Oh.
This is just Keynote 189.
Okay.
So this protocol has been around for a while. We started this a few years ago, and now we're happy to say that we're seeing a few patients in Canada that are getting it. It's not consistent across everyone. It's FDA approved, and it should be given to everyone right off the bat, first line. It's approved for first line metastatic non-squamous and for patients that don't have EGFR or ALK mutations.
Okay.
Doesn't mean that it's not going to benefit those patients. It just means this is a limited approval, and this is one thing that really bothers me is these limited approvals. It's like a way of weeding out patients and saying, sorry, we don't want to take a chance on you.
But isn't that because of the lack of patient stratification you were talking about, right?
Is.
They don't know how to tell for sure if it's going to work,
Exactly.
and budget's tight, sadly, for healthcare.
Yeah. So, great trial. We have a few patients on this right now. So it basically combines an old immunotherapy drug, literally the second immunotherapy drug ever designed, pembrolizumab. It was considered the second generation, and nivolumab was like the first, and pembrolizumab was the second. Pembrolizumab targets both the receptor and the ligand, the PD-1 receptor and the ligand. And so when you add that to standard chemotherapy, and the standard chemotherapy is pemetrexed and platinum-based, you can use cisplatin or carboplatin. We prefer carboplatin because carboplatin is easier on the kidneys and slightly better protocol. Cisplatin may work a little better, but not much. It's like maybe 1 or 2%, and it has more side effects that it can really damage your kidneys. So most doctors use carboplatin. Some will use cisplatin. So when you combine pembrolizumab and pemetrexed with a platinum drug, so the survival difference compared to standard chemotherapy is 22 months overall survival versus 10 months. And this is metastatic patients.
Wow.
Then there's another study called the IM Power 131, and this is used as another third generation PD-1 inhibitor called atezolizumab. And they combine that with chemotherapy versus chemotherapy alone as a first line for stage 4 squamous. This is for squamous, not for adenocarcinoma. Okay. Keynote 189 protocol is only for non-squamous. Okay. And so this was actually for squamous. And the survival difference is 23.4 months overall survival average versus 10 for chemotherapy.
Okay, and these are for late stage.
They're for advanced first line.
Okay.
So that's the difference. So these are patients that are going to have a really poor response because they're stage 4 as soon as they're diagnosed. It's in all their organs, not all, but many organs. but it's their first treatment.
Okay.
And then there's a Checkmate 227, and that should give you an indication of how many Checkmate studies have been out there. Checkmate is for nivolumab, and this is also first line. And so in this one, they combined nivolumab, which is the first generation PD-1 inhibitor, with ipilimumab, which is a CTLA-4 inhibitor that we discussed last week. And that's another form of immunotherapy, ipilimumab. And so the overall survival, the average medium, was 17 months versus 13.9 for the chemo. However, when you look at the statistics, things panned out a little differently. So the overall was 23 months for nivolumab and ipilimumab combination versus 15 for nivolumab alone. And then the 2-year survival rate was 40% for the combination, the two drugs together, and 33 for I believe it was the one drug. And then the progression-free survival was 23.2 months versus 6.2 months.
Wow.
For the chemotherapy.
Right. Wow. So adding in, was that for the combination, the nivolumab?
Yeah, so they did, the point was, what they wanted to do is they wanted to compare single agent to adding this CTLA-4 inhibitor.
Got it.
So they compared the two together.
Right. And it gave people a lot more time.
Big difference by adding ipilimumab, yes. So now we know, add ipilimumab with your PD-1 inhibitor.
Wow.
And so that's about it. I could go on and on and on, but yeah, I just wanted to cover our new faves. So those are our new 3 faves: the Keynote 189 protocol, the IM Power 131, and the Checkmate 227.
Okay, good.
Those are the ones we would be suggesting right now.
What's important if you're watching this video at any point, even a month down the road from now. While this information will still be true, there's almost certainly going to be some new information
there's so
as
much.
well.
And just today, there's so much information. You know, there's a lot of people making PD-1 inhibitors now.
So this is really inspiring. If you have lung cancer, there's so much that you can do. People, they're depending on the genetics, the molecular drivers of your cancer. There's, I mean, I'm still floored by that one study you were talking about.
With the KRAS inhibitor.
With like 100%. Wow. Wow, I'm just really...
That's a disease control rate. So the disease control rate is all 3 responses together.
Right.
It's...
56%
yeah,
had an
high.
Outrageously amazing response if they had that one genetic target.
So just to be clear, the disease control rate includes a complete response, a partial response, and a stable disease, because there are 3 different responders.
I understand. Okay, but I'm still excited.
Yes,
you can't stop me from
too.
being excited.
No,
There's some really, from a cancer that used to be really, exceptionally deadly and scary. This is really exciting for people, especially what you were talking about earlier about some folks who were, very late stage, had already tried 3 or 4 different types of treatment. Just adding certain things, modifying certain things, and knowing what genes are driving your cancer has given them years more life.
Exactly. Yes.
Thank you for watching Ketome TV. Subscribe below and stay informed.